Welcome to Infection and Immunity Evidence Explained, a Doherty Institute podcast. I'm Rebecca Elliott. We last spoke about COVID-19 on the podcast back in November with Professor Sharon Lewin, Director of the Doherty Institute. Sharon described it as an endemic infection, meaning that we are indeed now very much living with the virus, like we do for the flu, for example. Today I'll be asking my guest, as we officially move into the winter months here in Australia, where are we at with case numbers and when is the right time to get a booster shot? Here to answer these questions and more is Professor Ben Cowie. Ben is an infectious diseases physician and epidemiologist with the Royal Melbourne Hospital at the Doherty Institute, and he also serves as the Chief Health Officer in Victoria's Department of Health for 1 day a week. Professor Ben Cowie, welcome to Infection and Immunity Evidence Explained.
Thanks, Beck. It's great to be here.
So, what's the status of COVID-19 in Australia as we head into the winter months?
So we're currently got increased levels of COVID activity in the community. It's been mounting up over the last few weeks, and so as of now, we've got over 400 people in hospital with COVID-19 here in Victoria, so that represents more than double what it was a few weeks back, which is obviously of concern, but this is what we've come to expect of COVID-19, is that it goes through these waves or waxes and wanes over time, and unfortunately currently we're in a period of increased activity.
So without mandatory testing, how do we know that there are these rising cases? Is it through the hospitalisations, as you mentioned?
Yeah, so that's one of the key sources of data that we've got. So even while there was a requirement for people to report their positive results and for doctors to notify cases of COVID-19, as the pandemic progressed, we saw our ascertainment, or the proportion of people that we estimated that were being notified, dropping away. Really, because of how common COVID-19 did become once some of those public health and social measures were necessarily removed to allow us to get on with our lives to a greater degree. The two lines of evidence we use to the greatest degree to monitor what's happening with COVID-19 in the community is, yes, hospitalisations. So the number of people currently in hospital with a diagnosis of COVID-19. And that's something that we can then use to compare with previous modelling, looking at the number of people in hospital, the number of admissions on a given day, and how that relates to what's going on in the community. The other one is actually wastewater surveillance, so looking at both the relative abundance, so the amount of COVID-19 that's in our wastewater, and that also allows us to detect new emerging variants and monitor their relative expansion. So to a lesser degree, obviously also tragically looking at the people losing their lives with COVID-19 and the number of deaths, but that does lag behind waves of COVID-19 to a degree. So the two most timely things we have is hospitalisations and wastewater.
What are the factors that are contributing to the rising case numbers at the moment?
Yeah, so I guess one factor is the emergence of new variants. And basically what's driving that is COVID-19 the coronavirus that causes the disease COVID-19 is mutating to try and evade existing immunity, whether that's from previous infections or from vaccination. And so that then leads to the ability of COVID to break through our defences, and that is one of the determinants of that sort of rising and falling nature of transmission. There are other determinants, so how long it is since someone has had a case of COVID or has been vaccinated clearly relates to their risk of getting COVID-19. And so if you do have a previous wave that the immunity from that is starting to ebb, that is setting up the conditions where a new wave might happen as well. And then there is some seasonal impact. So despite the fact that we don't see the same sort of classic seasonality that we see with flu, for instance, we know that both because of our behaviour during winter time, but also some other factors of the virus and stability and cold weather, etc., that generally in the cooler months when people are clustering inside and might not have the windows open to the same degree, we do see greater potential for transmission during winter, like for other colds and coughs and viruses that cause respiratory infections.
Well, we learned a lot about variants during the height of the pandemic. What are the variants that are currently circulating, and are they of particular concern?
So currently all the variants that are circulating are successors to that big Omicron wave that we saw at the end of 21 into 2022, which led to our highest numbers of people in hospital and obviously put a strain, despite the fact it happened during the summertime, put a significant strain on our health system and on the community. So all of the variants we see now are sort of successors to that variant. The current dominant variants that we have circulating are JN1 and then some of the, again, further subvariants from there. So it's been described as FLIRT, the variants that are going around, as sort of a bit of an acronym or a nickname. But KP1 and 2, and then now in Victoria, KP3 is expanding the fastest. And that certainly is something that we see replicated around the globe, that KP3 is a variant of JN1, which is itself one of the Omicron group of viruses. They're the dominant variants. And they are expanding, certainly in our wastewater, quite significantly at the moment.
And what are the most common symptoms associated with these variants?
Yeah, so to a significant degree, it's still the same sort of symptoms that have been the case all the way through. So people getting a fever, sore throat, dry cough often, some shortness of breath, loss of sense of taste or smell, and nasal congestion. There's been some reports that maybe the more recent variants are associated with a greater degree of like runny nose or nasal congestion than previous, but essentially it's the same sort of symptoms that we've come to know from COVID and relates to a lot of respiratory infections. So whilst certainly the new mutations do confer an advantage in terms of getting through immunity and a greater risk of infection, at no stage really have we seen any of these variants of Omicron relate to a higher severity or greater likelihood of hospitalisation than others. So we haven't seen a greater severity variant emerge.
Well, that's very good news to hear.
Indeed it is.
So anecdotally, there seems to be some confusion amongst the general public as to how many COVID vaccines they should have had and when to get a booster.
Sure.
Can you please clarify for the audience when we have to get our boosters and how many vaccines should we have had?
Sure. So look, it really does depend on age, depends on underlying health conditions, particularly degree of immunosuppression. It's a lot easier now, actually. So ATAGI and the Commonwealth Government have, if you like, sort of made it more enduring settings around the vaccine recommendations. So if listeners like to Google COVID-19 Boosters Australia, then probably the number one hit will be the Australian Government website, where it does lead all that through. Essentially, anyone aged over 18 is eligible for a booster every 12 months. For someone who has reduced immune function, is aged 18 to 64, they're eligible every 6 months. And then as you go up through age groups, so for instance, for people aged 75 and over, it's recommended they get a booster every 6 months. And then, so it really does depend on which age group people are in and whether they've got an immune system that is compromised in any way. So recommend people Google, and essentially it'll recommend either eligibility or recommendation for vaccination every 6 to 12 months, depending on their age and immune function.
So what happens if I've had COVID-19, but I'm at that 12-month period?
Yeah.
What should I do? Should I get a booster?
So, yeah, look, it's safe to. There's no harm in getting a booster. The potential benefit of a booster is less immediately after someone's just had COVID-19 because their immune system is already primed by that infection. So if someone decides to defer their vaccination for, say, 2 or 3 months after having COVID-19 to try and get the best benefit of the immunity they've got from the infection before they then boost themselves, that's perfectly fine. But certainly there's no exclusion on getting a booster by having had COVID-19 recently, and there's no harm in getting it.
And so in terms of numbers of vaccines, it's not about numbers anymore, it's just about getting boosted.
That's right. And it's likely going to settle into something more similar to the sort of current, what we do with the flu. I mean, it's very different vaccinations and different ways they're manufactured, and flu mutates in a different way to what COVID does. But that said, it's still the idea that we like people to have immunity, we like them to have the protection that the vaccine confers, particularly against serious infection, and particularly for those at greatest risk. So it is settling down into a more of a time-based rather than have you had your third, have you had your fourth, have you had your fifth, etc.
What level of protection does a booster provide?
So we've seen over time that an individual booster has a somewhat reduced effect on protecting against getting infected at all than it did initially. We certainly saw the vaccines had quite a profound effect at helping prevent you getting COVID at all in the first phase when they were first being deployed. But for much the same reasons that the virus keeps mutating to evade immunity from infections, previous infections, that it is also the case that it evolves fast and to the point where it can break through vaccination. So we see less impact against getting infected at all, but we still see a very profound impact on serious illness, and particularly people needing to go to hospital or tragically losing their lives from COVID-19. So that's why the vaccine recommendations are different based on people's risk of those severe outcomes, and why people, particularly over the age of 75, are recommended to have vaccination or booster every 6 months, because what we're trying to do is to protect those at greatest risk of severe outcomes by using the vaccine, which still has got a really significant effect for some months after vaccination on those severe outcomes.
Well, that's good to hear too. So how soon after receiving a booster are we protected, and how long does it sort of tend to last?
Yeah, so it is already starting to boost the immune system within days, and certainly like a week after you've had your booster, you've got significant levels of immunity operating, and that's partly because essentially all of our immune systems have seen COVID in some way before, whether it's vaccination. We know that a very high proportion of our population, 95% or so, got the sort of first 2 doses of vaccine in the first year of the vaccine program. Amazing uptake. So all of our immune systems effectively have either seen the vaccine or infections, or for most of us, both at some stage in the past. But that does mean that our immune systems react quickly when exposed to COVID-19 or to vaccine. So yeah, within days, you'll have some measurable immunity and boost. In terms of how long it lasts, certainly we see a significant benefit in terms of those severe outcomes for some months after a booster dose, so at least 3 months. It probably wanes over time, and month by month there's still some benefit, but it gets less with every passing month, and hence the recommendations for 6-monthly boosters for those at greater risk.
So if someone is yet to receive their flu vaccine, we are, a month or 2 into the flu season, can they have the COVID-19 and the flu vaccine at the same time?
Yes, you can. And really, if you're due for both, get both, because there's plenty of flu around too.
Yeah, absolutely. And if someone does contract COVID-19 and they become quite unwell, what are the current treatments that we have on the market?
Yeah, so there are a number of different antivirals that work against COVID-19. I guess the way that is useful to think about is divided up between those that are prescribed in the community to try and prevent serious outcomes, and then those that we give in hospital when someone does come in with serious COVID and we need to treat them to try and sort of lessen their symptoms and prevent the sort of terrible outcomes that we've, again, tragically still see in hospital and in the community. So the ones in the community that are prescribed are called, so the first one is molnupiravir, otherwise known as Lagevrio is the trade name, and the other one is nirmatrelvir ritonavir, otherwise known as Paxlovid, and everyone knows it as Paxlovid. So these are the 2 antivirals that GPs will prescribe if someone presents with COVID-19 and they're eligible.
Yes, I want to talk about that eligibility.
Sure.
What is the eligibility for those
So
drugs?
again, it's sort of similar to the vaccination situation. It's a mix of age and then risk factors for serious infection. So I guess the first thing to remember is that everyone aged 70 and over is eligible for these antivirals. So anyone who's aged 70 or older should have a plan with their GP that if they get COVID-19 and test positive, whether that's by RAT or by PCR, so a rapid antigen test, that's fine. They can get in touch and get their antivirals. And we know that timeliness is critical. The sooner that someone starts the antivirals, then the best prevention of hospitalisation and loss of life. So everyone aged over 70. For people aged 50 and over, with a couple of other risk factors, things like heart disease or liver disease, kidney disease, people living in residential aged care facilities, people with serious disabilities or a range of other factors, if they're aged 50 and over and have 2 of those risk factors, then they're eligible. For Aboriginal and Torres Strait Islander people aged 30 and over with one risk factor, they're eligible. And then the other group that we consider is anyone aged over 18 who's got serious immune compromise, so immune system's not working properly, or if they've ever ended up in hospital with COVID before, and they're eligible as well. So again, if someone Googles sort of Australia COVID antiviral eligibility, all of this is very clearly laid out, and it's really well worth having a chat if you are eligible or thinking you may be eligible. Booking an appointment with your GP up front and sorting out both which antiviral is best for you and what your plan is to get it from which pharmacy, and make sure that those systems are in place, because we know the sooner people get treated, we've done studies of this in Victoria, very substantial impact of these drugs on preventing people from ending up in hospital or losing their life.
And is that eligibility likely to change, or is it just not really needed for people that are sort of under 50 in relatively good health, all of that sort of thing?
So it has changed over time. There's been several iterations where the eligibility has sort of opened up over time. I would anticipate that will continue to be the case. It really depends on both evidence from clinical trials or from other research that shows benefit in different age groups or in different risk factors, and that information changes over time. So I don't think it'll be locked in stone now. I think that eligibility will change, and certainly it is possible for people to obtain them on private scripts outside those eligibility criteria, but they're quite expensive, and so it's more than $1,000 a course for someone wanting to buy it for their own use, with a prescription, of course. So, and that has been sort of, I guess, people have been recommended to not do that to the same degree, particularly when they're in shorter supply, to allow those with greatest evidence of benefit to get them.
All right, well, we know that there's a lot of flu circulating, a bit of RSV and COVID-19. What else should we be doing to protect ourselves from these respiratory illnesses this winter?
Yep, so besides vaccination, obviously, against both COVID and flu, aside from vaccination. So, look, this is the stuff that we've learned over the years. So things like, if you're sick, don't go to work, don't visit friends, stay home, look after yourself, get looked after by those around you, and keep them safe as well. It really is important that if we're sick, we stay home until we recover. Wearing of masks certainly helps, and surgical masks have benefit. The P2 or N95 masks have greater benefit, but any of those masks really do significantly reduce the risk of COVID-19 of getting infected if you're in crowded places or if you are in contact with people who may be unwell. But it also helps protect others from us. If we're in that sort of early phase of infection, we may not have symptoms. So certainly during periods of increased transmission, if you're in a crowded environment or where you can't socially distance, it's worth considering a mask. Otherwise, sort of as much as possible during the winter time, gathering outside or leaving windows open, getting plenty of fresh air. We've learned the importance of fresh air and good ventilation, and these are not things we can ignore going forward, both in terms of how we behave, but in terms of building design, and particularly thinking about healthcare facilities and also places like aged care facilities. We've really got to have a strong focus on ventilation there going forward. And then all those really sort of simple measures that we've learned, but it's important to keep going with. It's not just about COVID, it's about all the other ones too.
Well, that's a pretty good place to leave it. Thank you so much for joining me today, Ben.
Oh, thanks so much, Beck. Lovely to talk to you.
And thanks to all of you for listening to Infection and Immunity Evidence Explained, a Doherty Institute podcast. If there is a specific topic you would like us to cover, please get in touch with us by emailing doherty-media@unimelb.edu.au. That's doherty-media@unimelb.edu.au. If you've enjoyed our podcast, please rate and review on your favourite podcasting app and subscribe if you haven't already. The Doherty Institute is a joint venture between the University of Melbourne and the Royal Melbourne Hospital. See you next time.